Hello, my name is Keith Varnes, and this course is Common Rapid Response Team Interventions. It is approved by the AARC for 1 CRCE credit hour. We do not have any financial sponsors for this course. The objective today is quite simple: to explain treatment options for common medical emergencies encountered by rapid response teams. I can't explain all situations you might encounter in 1 hour, so I tried to hit many that I have encountered working at a Level 1 trauma center. To appreciate rapid response teams, you need to begin at the beginning. Let's do a little history lesson. In the early 1990s, critical care physicians, primarily in Australia, Pittsburgh, Pennsylvania, and the United Kingdom, began questioning what happened to patients in the minutes to hours before codes occurred. Could an early intervention have changed the course for these patients? Prior to this time, the emphasis was on improving CPR and ACLS. Unfortunately, outcomes for CPR are not good. Most physicians at that time were well aware that patients on the floors rarely went from being just fine to all of a sudden crashing and being sent to ICU. There was usually a period of time where a gradual deterioration occurred. The early studies proved this to be correct. Most often, there are long periods of hemodynamic and respiratory instability. Was there an opportunity to intervene and change the clinical course before the crash? Born was the idea of the rapid response team. Early programs were also called medical emergency response teams, or METs. At my hospital, they are called MET teams, which, if you think about it, stands for Medical Emergency Response Teams Team. Kind of strange. They're also called Condition C teams and Critical Care Outreach teams. Regardless of the name, they all functioned for the same purpose. Early studies allowed physicians to come up with physiologic indicators, or criteria, that can be used by general care staff as a guide to decide when to call for help. Here are some examples of why a MET might be activated. Any staff member may call the MET team if one of the following criteria is met: heart rate over 140 or less than 40, respiratory rate over 28 or less than 8, blood pressure greater than 180 or less than 90, oxygen saturation less than 90% despite supplementation, acute change in mental status, urine output less than 50 cc's over 4 hours, or a staff member has a significant concern about the patient's condition. Additional criteria used at some institutions: chest pain unrelieved by nitroglycerin, threatened airway, seizure, and uncontrolled pain. The linking of healthcare providers at the bedside with the ability to activate a specialized team of responders has been embraced by the Joint Commission as one of their national patient safety goals. The Joint Commission doesn't specifically mandate specialty teams, but does want healthcare providers to be able to request additional assistance from specially trained individuals when a patient's condition deteriorates. This was brought on by the 2008 Joint Commission National Patient Safety Goal, which required hospitals to implement systems to enable healthcare staff members to directly request additional assistance from a specially trained individual or individuals when the patient's condition appears to be worsening. The reason I wanted to talk about the rapid response team was that it isn't just about the responding team, it's an entire system. This system refers to the system responding to the patients with critical medical needs. The first part of the system is the activation process. Who can call and when? This is known as the afferent limb. General ward staff need to be trained on when to call and feel confident about calling. Then, of course, there is the responding team, known as the efferent limb. These responding teams may be the cardiac arrest team, difficult airway team, MET team, etc. However, there is also a component of the system that continually evaluates the performance of the emergency team system and has a quality improvement process in place to help improve it. Finally, The administrative limb is responsible for providing the resources needed, both equipment and personnel. The effective use of a medical response team system has to be a cultural element of your healthcare system. Doctors and nurses feeling that calling for help is a sign of weakness just won't do. Specialized teams that include a physician, a nurse, maybe a respiratory therapist, and possibly others are known as medical emergency teams. Teams that don't include a physician are known as rapid response teams. For a rapid response team, physicians may not be part of the initial bedside response, but they are available for consultation if necessary. While nurses can't write orders, nurse practitioners in the United States can. As a point of interest for those of you who know our company history, at Cadillac Medical Center in Washington State, they chose to call their team the Rapid Assessment Team, or RAT. They have signs, t-shirts, even toy rats on the units that remind nurses to call the RAT if they need help. For those wondering what does this have to do with us, our company originally did staffing for hospitals across North Texas and continuing education under the name Respiratory Associates of Texas, aka RATS. We even had a rat logo and made respiratory cartoons and comics. However, even though the main screen on our website stated AARC approved, accepted throughout the United States, many people would call every day asking if the courses were accepted in their state, since the name was Respiratory Associates of Texas. Eventually, we dropped the of Texas, changed our logo, and all those calls went away. While most would think the rapid response team is most important, the afferent limb is equally important, if not more so. Knowing when to get help is vital. If you wait until the arrest is imminent, you waited too long. Improving outcomes is often achieved by improving when to call. When are there unmet patient needs? Objective criteria is best, and several scoring systems exist to help with when to call. At my hospital, one scoring system is called the MUSE score, or Modified Early Warning Score. The primary purpose is fairly simple: to prevent delay in intervention or transfer of critically ill patients. This is an example from the Open Anesthesia Journal and is called a NEWS, National Early Warning Score. The patient's vital signs are measured and then a score is compiled based upon those measurements. Now that we have learned about rapid response systems in general, let's get into the heart of this presentation, some common medical emergencies that you might encounter as part of a rapid response team. This should not be new information to most of you, but I remember being handed the code radio on my first day as a respiratory therapist. I had the towers, also known as the floors, and that therapist also carries the code radio. I was scared to death. I work at the county hospital and assumed, although incorrectly, there were going to be codes and dead people every day, all day long. That didn't happen. But I certainly feel more confident now than I did then. Signs of respiratory distress include increased rate. This can have many causes, including hypoxemia, hypoxia, and by the way, those aren't the same, acidosis, etc. A bluish color known as cyanosis is sometimes seen around the mouth, on the inside of the lips, or on the fingernails, and may happen with decreased oxygenation. The skin may also appear pale or gray. A grunting sound can be heard each time the person exhales. This grunting is the body's way of trying to create PEEP. Nasal flaring may be seen, where the opening of the nose spread open. That might be noted. For retractions, the chest appears to sink in just below the neck, under the sternum, or between the ribs with each breath. There may be increased sweat on the head, but the skin does not feel warm to the touch. The skin may actually feel cool or clammy, and this may happen when the respiratory rate is very fast. Wheezing might be heard both on inspiration and expiration. You should try to distinguish upper or lower airway wheezing. The fix is not the same. Body position. A person may spontaneously lean forward while sitting to help take deeper breaths. This is known as tripoding and is an ominous sign. The patient may be desaturating. A respiratory therapist at a minimum should always have a portable pulse ox and stethoscope available. If they are not on a SAT monitor, you should quickly whip out your finger probe. Depending on their perfusion state or how low the SAT actually is, this might not work. If necessary, get an ABG. Stimulate the patient. Speak loudly to them. Gently shake them. A sternal rub if necessary. If the patient has a functional airway, reposition the patient. Pull them up in bed. Open the airway. If unconscious, consider an OPA. If they are answering questions, I would assume they are not unconscious. If conscious, you can use an NPA. If respirations are inadequate, they need ventilation. Remember, the 4 basic life functions are ventilation, oxygenation, circulation, and perfusion. Your patient can't oxygenate if they are not ventilating first. They are either breathing adequately or they aren't. Kind of breathing is the same as not breathing. Putting a non-rebreather on a patient that isn't breathing does nothing. If oxygen is needed for emergencies, I like to grab a non-rebreather. Short bursts of 100% oxygen aren't going to hurt anyone, but titrate it down as soon as possible. Remember, the more oxygen you use, the worse the outcome. Of course, this could also mean the sicker the patient, the more oxygen is required. Which came first, the chicken or the egg? If the patient was recently given a medication like opioids or anesthesia, ask if there is a reversing agent available. Intubate if necessary. It is far better to intubate in a controlled environment like the ICU than to do a crash intubation on the general floor somewhere. You will have a much stronger resource pool in the ICU. Perhaps the patient has aspirated his dinner. You need to remove the object as quickly as possible. However, do not perform a blind finger sweep on anyone, as you may shove the item deeper, and if you ever stick your fingers in the patient's mouth, you might not get them back. I once was extubating a patient, and as I was pulling the tube out, he bit down on it. Now the tube was halfway out and I couldn't move it. His jaw was locked so tight we couldn't force it open. I eventually had to wedge a 10cc syringe into his teeth to get it out. It was a scary few moments. Imagine if that tube was my fingers. Angioedema can be caused by allergic reactions, medication reactions, extubation side effects, etc. I've had several patients that had angioedema due to reactions to ACE inhibitors. As you probably know, ACE inhibitors are often prescribed for hypertension. For that situation, the best course of action is to protect the airway, intubate if needed, and change the medication to something else. It generally resolves in a few days. Treatments include steroids, which take 1 to 2 hours to take effect, racemic epi, IM epi, Heliox, and CPAP. Intubation will likely be difficult. I would suggest using a video assist device like a glide scope or doing it in the OR. Be prepared for a surgical airway. If there is bleeding, the best course of action is to try to determine where they are bleeding from and fix it. Other causes for low saturation is pulmonary embolism and shunting. If PE is suspected, then put them on a non-rebreather, although there may be minimal response to oxygen. You can use dead space calculations with an ABG and end-tidal CO2. D-dimer levels above 500 suggest the possibility of clots, although there can be other causes of an elevated D-dimer. Normal levels rule it out. VQ scans, which are generally not used much anymore, CT scans, and the gold standard pulmonary angiography. The treatment for PE is heparin. Heparin is an anticoagulant, so it doesn't dissolve the clot, but it keeps it from getting bigger. Thrombolytic agents like alteplase, which actually dissolve the clot, may be considered, but there is a risk of bleeding associated with these agents. Thrombectomy can be used where a wire is inserted, they grab the clot and remove it mechanically. Shunting is where blood is bypassing the lungs and therefore not participating in gas exchange. The fix is determined by the cause. If you turn up the PEEP and the saturations drop, perhaps your patient has a PFO. Remember that 98% of your oxygen is carried by hemoglobin. Decreased hemoglobin levels can be caused by loss, as with GI bleeding or trauma. Hemolysis, or the destruction of red blood cells, known as hemolytic anemia, which will develop if bone marrow activity cannot compensate for the erythrocyte loss. Coagulation can cause a decrease in available red blood cells, and overclotting of blood can result in deep vein thrombosis, known as DVTs. Of course, there are the hemoglobin abnormalities like methemoglobinemia, sulfhemoglobinemia, sickle cell anemia, etc., what I call broken hemoglobin. If you are unfamiliar with these, I suggest taking our course on hemoglobin abnormalities. Another cause for low oxygenation is low cardiac output. Some causes for low cardiac output are acidosis, myocardial infarction, decreased contractility, medications, low volume, increased intrathoracic pressure, bradycardia, and hyperthermia. Another cause for low oxygenation is low systemic vascular resistance, causing low blood pressure. The blood volume remains the same, just the vessel size has increased. Some causes are sepsis. You'll probably get an ABG and find high lactate. This is an infection in the blood, so blood cultures and antibiotics are indicated. What I call the bug and the drug. What is it and what will kill it? Pancreatitis, uncompensated liver disease, medications that block the sympathetic nervous system, such as some beta blockers. Give fluids, support cardiac output, find and fix the cause. Neurogenic altered mental status. AMS can be caused by low oxygen delivery, low glucose, medications, so you'll check the patient's pupils. Big pupils are indicative of sympathetic overactivity and anticholinergic toxicity. Small pupils are indicative of opioid and cholinergic toxicity. If the cause cannot be identified, you might consider a CT scan. Here is an example of big pupils. And here is one of small pupils. For seizures, you can use a benzodiazepine like lorazepam or midazolam, but it will probably stop on its own within 2 minutes or before the meds can get there. If the seizure lasts longer than 5 minutes, then that is called status epilepticus. This is a neurologic emergency. Status epilepticus can cause respiratory failure, cardiovascular collapse, and neurologic damage if not stopped. You might need to intubate and use vasopressors. Obviously, anti-epileptic medications will be required. For refractory, which is a fancy word for they still got it, status epilepticus, consider anesthesia and mechanical ventilation. Possible anesthesia agents are midazolam, propofol, and ketamine. If your patient with a history of seizures is positive for benzos, that doesn't mean he is a drug addict. Benzodiazepines are used to control seizures, so that would be expected. Also, you wouldn't want to give a benzodiazepine reversing agent like flumazenil, known as romazicon, as that might lead to more seizures. Let's move on to arrhythmias. There are 3 main types of tachycardia: supraventricular, ventricular, and sinus tachycardia. Common causes are exercise, fever, fear, stress, anxiety, certain medications, hypoxemia, hypoxia, acidosis, and, of course, street drugs. Common symptoms include dizziness, lightheadedness, shortness of breath, chest pain, and palpitations. Bradycardia is a heart rate less than 60, but you probably won't see symptoms until the heart rate is less than 50. Common symptoms are chest pain, confusion or memory problems, dizziness, easily tiring during activity, fatigue, syncope, and shortness of breath. For cardiac issues, check SAT, give oxygen if needed, put them on a monitor or get an ECG, establish IV or IO access if required, support blood pressure. Supraventricular, supra meaning above the ventricles, happens when the electrical signals in the upper chambers misfire and cause the heart rate to speed up. Concerning is that the heart can't refill completely with blood before it contracts, causing decreased cardiac output. Note there are no P waves. Use the American Heart Association tachycardia algorithm and trivagal maneuvers. According to AHA, that will work approximately 25% of the time. If that fails, try adenosine. Then you could try beta blockers, calcium channel blockers. If the patient has unstable vital signs, then you can do synchronized cardioversion. For cardioversion, you will use about half as much electricity as a defibrillation dose. For adults, start at 50 to 100 joules. Ventricular tachycardia is also known as VTach. This is a rapid heart rate that starts in the ventricles. First is to verify the patient has a pulse. No, start CPR. Yes, again, use the tachycardic algorithm. If that fails, then perhaps catheter procedures or surgery. Sinus tach happens when the heart's natural pacemaker sends out signals faster than normal. Note there is a P wave. Again, use the tachycardia algorithm. For bradycardia, use the bradycardia algorithm. This is an example of sinus bradycardia, but they might also have a heart block. Heart blocks are not blood flow blocks, like a thrombosis, but an electrical conduction block. For asymptomatic bradycardia, get history and physical. If they're having symptoms, try atropine 1 mg. You can give that every 3 to 5 minutes, up to a maximum of 3 mg total. If that fails, do one of these: transcutaneous pacing, epi, or a dopamine drip. For a further discussion on arrhythmias, please see our course ACLS Primer. Shock causes inadequate perfusion of tissues to meet metabolic requirements. Anaerobic metabolism causes an increase in lactate. It also causes a release of intracellular substances to the system and accumulation of metabolic waste. Support blood pressure with fluids, drugs, and blood. Shock is placed into 4 categories, which correspond to its underlying causes. These categories are hypovolemic, distributive, cardiogenic, and obstructive. Hypovolemic shock is due to loss of volume. Give fluids, primarily crystalloids or blood products. The complications of blood products include immune reactions like anaphylaxis, non-immune reactions like fluid overload, infections such as Hep C and HIV. It can also cause a left shift of the oxyhemoglobin dissociation curve due to decreased levels of 2,3-DPG. This causes the hemoglobin to grab onto the oxygen, but not release it to the tissues. This would cause non-hypoxemic hypoxia. The O2 in the blood is fine, the PO2 looks good, but the tissues are hypoxic. In distributive, also known as septic shock, there is no loss of blood volume, however there is a loss of blood pressure that is due to fluid distribution outside of the intravascular space or due to vasodilation, which makes the vascular space larger and increases the reservoir size. This is a blood infection, which we discussed earlier, blood cultures, and antibiotics. Cardiogenic shock is a problem with the heart itself, perhaps an MI. If you suspect cardiogenic shock, be careful when giving fluids. If time allows, get a chest x-ray. There may be poor response to oxygen. If you suspect acute coronary syndrome, suggest aspirin, which is used as an antithrombotic. For pain relief, you can give nitro sprays under the tongue up to 3 times, 3 to 5 minutes apart. If that fails to relieve their pain, then morphine is also an option. Be on guard, as morphine will not only knock out their pain, but also their breathing. The patient may need IV thrombolytics or a trip to the cath lab. Obstructive shock is caused by something obstructing the mechanical beating of the heart, perhaps pneumothorax or cardiac tamponade. Unstable pneumothorax requires needle aspiration. For a spontaneous pneumothorax less than 15% without symptoms, give 100% oxygen and observe and monitor. For a pneumothorax less than 15% with symptoms, then needle aspiration. For pneumothorax greater than 15%, a pigtail catheter to low suction or water seal. If unresolved after 5 days, consult a cardiac surgeon for consideration of a VATS procedure, which is a video-assisted thoracoscopic surgery, pleurodesis, laser treatment, resection of blebs or pleura, or an open thoracotomy. Acute cardiac tamponade will cause decreased venous return, so try to avoid mechanical ventilation. Support blood pressure. If the patient is stable, then treat the underlying cause. Since they called the MET team, it would seem this patient is unstable. Pericardiocentesis, or perhaps going to the OR for a pericardial window. Bottom line on these, the fix is to resolve the offending issue. Respiratory arrest means the patient has stopped breathing but has a heartbeat. Support ventilation. Cardiac arrest. Start with high-quality CPR, as that is the foundation of resuscitation. Start with compressions. If you want to challenge your cardiovascular system, try doing compressions with an N95 on. I did that recently and was surprised how fast I was running out of breath. Luckily, your primary job as an RT will be airway. Make sure you have suction, a BVM with a PEEP valve, and prepare to intubate. When I open an airway tray, I know where all the equipment I use is located. Try to keep the tray organized. I once had a tech open the airway tray, rifle through everything, and then finding anything later on was very time-consuming. In a code, time is short. Be sure to verify proper tube placement and secure it. Mechanically ventilate. Expect to get an ABG and transport to ICU. Depending on the length of time for CPR, expect the patient to be acidotic, which means initial faster respiratory rates. If you need to brush up on ABG manipulation with mechanical ventilation, you should check out my course on ABG analysis and interpretation. The best way to save this person's life is to figure out what caused the cardiac arrest and fix it. The primary reversible reasons people try to die are called the H's and T's. There are 5 H's and 5 T's. Hypoxia, hypovolemia, hydrogen ions, which is acidosis, hypokalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, coronary thrombosis, and pulmonary thrombosis. At a minimum, you should know the respiratory ones. The next time you take ACLS or PALS, be sure to pay attention to team dynamics. Knowing how to behave is just as important as knowing what to do in a code. For acute agitation, use benzodiazepines or antipsychotics. If those are ineffective, consider ketamine. Severe alcohol withdrawal commonly manifests with diaphoresis, nausea, vomiting, tremor, and anxiety. The treatment is to reduce severity of symptoms and prevent delirium tremens. The best way to achieve this is symptom-triggered benzodiazepines, so benzo pushes. Of course, the primary fix is time. The patient will just have to get through it. For opioid overdose, give naloxone, also known as Narcan. If it's a life-threatening situation, give a higher dose, 0.4 milligrams to 2 milligrams rapid IV push. Non-life-threatening, give a lower dose of 0.04 to 0.08 milligrams every minute until you get a response. For long-acting opioids, consider a Narcan infusion. Naloxone takes effect within 1 minute and will last about an hour. It competes for the same receptor sites as opioids and will have an immediate effect. If you give this to a post-surgical patient, you will remove their pain control and won't be able to get it back until the Narcan wears off, or about an hour. Until then, they are in excruciating pain. Also, acute withdrawal may cause agitation and put the staff at risk. Are they ventilating and oxygenating? Do you have time for a slow reversal rather than a fast one? A hypertensive emergency is defined as hypertension causing end organ damage. The fix depends on the cause. This is not an all-inclusive list, and I will go into a few in more detail, but it could be caused by or be causing ischemic stroke. Use labetalol to get the systolic pressure less than 185. Hemorrhagic stroke. Again, use labetalol. Head trauma. Mannitol. Encephalopathy. Nicardipine. Acute heart failure. Loop diuretics. Heart failure is when the heart can't keep up with demand. Removing some of the volume and taking that pressure off the heart is the ultimate goal. For acute coronary syndrome, nitroglycerin. Acute aortic dissection, nitroprusside. The target is 100 to 120 millimeters of mercury within 20 minutes. Pregnancy, use mag sulfate. Try to drop the systolic pressure 10 to 20% in the first hour, plus an additional 5 to 15% in the next 24 hours. Hypoglycemia is a common reason for a rapid response activation. Common causes are medications like insulin, anti-diabetic medications without appropriate carbohydrate intake, and critical illnesses like sepsis, trauma, and organ failure. A normal fasting, so no food for 8 hours, blood sugar level is between 70 and 99 milligrams per deciliter. A normal blood sugar level 2 hours after eating is less than 140. Mild hypoglycemia would be less than 70, with mild or perhaps no symptoms. Severe would be less than 40 and causing neurological issues. Remember, this is causing a lack of ATP generation. In turn, that can cause adrenergic signs, meaning relating to or denoting nerve cells in which epinephrine, known as adrenaline, norepinephrine, known as noradrenaline, or similar substances act as neurotransmitters. The patient may have anxiety, irritability, dizziness, diaphoresis, pallor, tachycardia, headache, tremors, and hunger. CNS signs are altered mental status, headache, malaise, impaired concentration, confusion, disorientation, irritability, lethargy, slurred speech, and uncontrolled behavior. It can also lead to seizures and hemiplegia. Glucose levels less than 10 lead to coma, pupillary dilation, shallow breathing, bradycardia, and hypotonicity. The fix is to give glucose, 20 grams of oral gel tablets or 4 ounces of orange juice. If they have an IV, you could give 50% dextrose, or if none of that is available, then give glucagon IM. This stimulates adrenal cyclase to increase cyclic AMP. You'll want to recheck the glucose 15 minutes after initial treatment, and you need to investigate the cause. Hyperkalemia is potassium levels greater than 5.5, but you probably won't have issues until it is over 7. However, patients with chronically high potassium, but less than 7, may still have issues. You might see flattened P waves, widened QRSs, peaked T waves, muscle weakness, and paralysis. Here is an example of an ECG with peaked T waves. You want to protect the cardiac membrane with calcium chloride 1 gram IV push or calcium gluconate 2 grams IV over 15 minutes. Calcium gluconate is preferred unless there are life-threatening arrhythmias. Calcium gluconate is less potent but less irritating. Hide the potassium from the heart with insulin and dextrose. Insulin forces potassium into the cells, temporarily hiding it. Occasionally I see an order for 10 milligrams of albuterol. This is also in an effort to shift the potassium into the cells, but certainly not as effective as other treatments. Ultimately, the fix is to send them for hemodialysis and remove the potassium. If the patient's condition worsens, be ready for a cardiac arrest. Acute decompensated heart failure refers to rapid onset fluid overload. This is usually caused by medication and dietary noncompliance. I'm sure you have all taken care of patients that ran out of their Lasix or overdid it on Thanksgiving. This could also be caused by arrhythmias, hypertension, acute coronary syndrome, and endocarditis. Some of the initial treatments would be Lasix. If Lasix doesn't work, you could consider hemodialysis to pull off the fluid, dobutamine, non-invasive ventilation, and possibly nitro if they have chest pain. Nitro is a vasodilator. Before giving it, make sure they haven't taken any phosphodiesterase inhibitors for erectile dysfunction prior to giving it. Those also work through vasodilation, and the combination of both may dangerously drop their blood pressure. You should probably ask about those when the patient is alone. Ultimately, you need to figure out what precipitated this and fix it. AFib with RVR, which is rapid ventricular response. Common symptoms are fatigue, palpitations, angina, dyspnea, orthopnea, dizziness, and syncope. Treatment is through rate control. Try to get the heart rate down to under 110. A few of the treatment choices are metoprolol, verapamil, and amiodarone. If all else fails, ablation could be considered. Assess stroke risk. Since the atria are quivering, they aren't moving the blood efficiently. When the blood doesn't move, it coagulates, which can cause thrombosis. Asthma exacerbation. We see these patients all the time. Of course, by the time they come to my ER, they have already taken at least 10 treatments at home that didn't work. So the doc orders me to give a few more. Many patients don't take their medications or don't take them correctly. Just because it didn't work for them doesn't mean it won't work for you. Give bronchodilators and steroids. Steroids will take 1 to 2 hours to take effect. If they can tolerate it, check peak expiratory flow. Give treatments every 4 to 6 hours until they can achieve 70% of their personal best. The patient may not know their personal best, may not use a peak flow meter, obviously doesn't control their asthma. Here is your chance to be a respiratory therapist and educate them on asthma controlling strategies. Consider mag sulfate 2 grams over 20 minutes. Maybe BiPAP, and if things go bad, prepare to intubate. Asthma is an obstructive issue which causes a problem of getting air out of the lungs. So try to achieve an IDE ratio of 1 to 4 or 1 to 5. The more air the patient can get out, then the more air they can get in on the next breath. On discharge, they will probably have 7 to 10 days of oral steroids. They need good discharge planning and to be scheduled for a follow-up visit. We have a course on classification and management of asthma if you are interested. COPD exacerbation. Now, COPD is another obstructive problem. These patients generally live in a chronic compensated acidosis, meaning high PCO2, high bicarb, and normal pH. Occasionally, something makes them acutely worse, like a lung infection. This sends their CO2 even higher, and they end up with acute on-chronic respiratory failure. Duoneb, oral IV steroids, antibiotics, possibly NIV. Be careful using invasive ventilation, as the patient may never come off the vent. Make sure the patient is up to date on all their vaccines, especially pneumonia and COVID. I know some respiratory therapists that don't believe in any vaccines: polio, measles, smallpox, flu, COVID, whatever. This is probably because they have very little personal experience with these diseases because in the United States, most of these have been eradicated thanks to vaccines. Regardless of your personal feelings about the COVID vaccines, you need to encourage your patients to take them. If they smoke, suggest smoking cessation programs. Although I often tell my patients I am the world's worst respiratory therapist as I can't even get my own mother to quit smoking. Encourage exercise. Asthma and COPD are two conditions respiratory therapists should be experts at treating. This means you guys. Accidental trach decannulation. This is usually caused by the patient coughing while the trach ties are being changed, or perhaps the patient simply pulling it out. You should always maintain control of the airway, but things can and do happen. If it is less than 7 days old, do not try to put it back in. Orally intubate and send to the OR for reinsertion. If it has been longer than 7 days since it was placed, you can try to put it back in. There should be readily available safety equipment in the room. At my hospital, we require an obturator, BVM, extra trachs, same size and one size smaller, colorimetric CO2 detector, suction supplies, extra inner cannulas, and suture removal kits to be available at the bedside. Once you have been in the room, you are responsible if any of the safety equipment is missing. You need to check this during first rounds and replace anything that is missing. First thing is, don't panic. That will just make the situation worse. An established stoma won't close in seconds, it will take hours. Call for help just in case you need it. The nurse may not be skilled in trach reinsertion, but she could help hold the trach or get supplies. Grab a new trach, insert the obturator, lube it, and insert it. Remove the obturator, attach the end-tidal CO2 detector, look for color change. Ventilate if necessary and listen for breath sounds. Secure it. If all else fails, you will have to seal off the stoma and mask ventilate. Life-threatening hemoptysis. This person is coughing up buckets of blood. So much so it is causing airway obstruction, asphyxiation, and hemodynamic instability. This is not only a scary situation, it looks scary as there is lots of blood. Gowns, gloves, face shield, or other eye protection is a must. The first thing to do is to get an x-ray and try and determine which lung the bleeding is coming from. Put the patient in the lateral decubitus position, meaning on their side, with the bleeding lung down. You are trying to keep the blood out of the good lung. Start volume resuscitation. Give blood products if needed. Stop all anticoagulants. Intubate and bronch. You could also selectively intubate only the unaffected lung. Once you have stabilized the airway and hemodynamics, consider bronchial artery embolization. Acute ischemic stroke. So an ischemic stroke is a blood clot in the brain. A hemorrhagic stroke is a brain bleed. So you want to get a CT scan done within 20 minutes, and you want to have it done and read within 45 minutes. CT scan is to rule out a hemorrhagic stroke. If the patient is hypertensive, treat it to get it lowered to 185/110. Labetalol would be a good choice. If it is within 3 hours of onset, you can give a thrombolytic like Alteplase. If outside the treatment window, then the patient will have to go to rehab. Let's summarize and review a little. We talked about the history of the rapid response team, how physicians in the 1990s recognized there might be opportunities to intervene when patients are clinically deteriorating and change the clinical course. Born was the idea of the medical emergency response team. We covered reasons a rapid response might be called, that the Joint Commission in 2008 made the ability for staff to call specially trained personnel a national patient safety goal. We then covered the 4 parts of a rapid response system: the afferent limb, efferent limb, QI, and administration. Then we discussed scoring systems that are used to trigger a rapid response. Finally, we covered common rapid response emergencies, including respiratory, cardiac, neurological, alcohol withdrawal, opioids, hypertension, hypoglycemia, and tracheostomy misadventures, along with a few others. In closing, I would like to say that you will feel much more part of the team if you have a better understanding of the situation. When you're taking care of patients and you understand their condition and the general path of their care, you feel more connected to the outcome. Don't just show up, do the treatment or procedure, and leave. Be better than that. Some therapists have jobs, others have careers. Get passionate about this and make it your career. To quote my friend Joe Lewis, the respiratory coach from YouTube, average is easy. Don't be average. Here are the references I used in the creation of this presentation. This brings us to everyone's favorite slide, the end.